So today's objectives are to describe the hazards that are faced in the hospital by older adults. We want to have a good grasp of what never events are. We want to refine how we assess the hospitalized older adult, and then look at some new systems of care for older patients in both the acute care and in transitions of care arena. So the topics that we're going to cover are hazards of hospitalization, the risk of functional disability as a result of hospitalization, the risk of delirium, suboptimal pharmacotherapy, and what does that look like, the issue of sleep disturbances, and nutrition. The never events, of which there are many, according to Medicare or CMS, we will focus primarily on geriatric never events, falls, CAUTI, C-A-U-T-I, which is catheter-associated bladder infections, and pressure injuries. We'll also talk about the assessment and management of the older adult hospitalized patient. We want to look at some special considerations, for instance, the intensive care in the emergency room, what goes on there with the older adult. Look at some models of healthcare. What are the alternatives to hospital care? And as I told our UND medical students just the other day, the most singular, most expensive or cost in Medicare is acute hospitalization. So if anybody was to have a way to reduce costs of Medicare, the first thing that should be looked at is the overutilization of hospitals. So this graph, which has I'm taking art classes these days, and I don't know why I put purple and green together. I guess they're complementary colors. I'm not sure it shows so well. It's a pretty bright graph here. But anyways, you can see the percentage of hospitalizations in the middle there, in the middle graph, and that this is actually a low number. Probably represents data from a few years ago. And in fact, the percent of patients in hospitals now is, that are over the age of 65 is closer to 55%. The most frequent diagnoses that occur for hospitalized older adults are heart failure, pneumonia, which includes both viral and bacterial pneumonia, and certainly COVID has bumped that up quite a bit, cardiac arrhythmias, and then heart attacks, basically, or angina. So I just want to, at the offset here, mention our overall interest in social determinants of health, diversity, and equity as they relate to acute care. And it has been noted that patients that are underrepresented populations commonly are treated at facilities where the outcomes are not always the best. These hospitals tend to represent the lower quintile on quality measurements, and I certainly am not one to use quality measures as the be-all and end-all of quality, but it is somewhat of a metric that we can do comparisons and recognize the fact that the best of care is not always provided with the poorest amongst us. And in particular, there's huge disparities in cancer. So, for example, the access to personalized treatment plans is often not accessed by underrepresented populations. So I also want to point out this whole issue of ageism. This is it was an issue a while back. Geriatrics came up. We said, oh, we fixed ageism, and and then somebody said, oh, look out because there's so many older people. There's a silver tsunami. And I was kind of twiddling my silver hair, and I thought to myself, yeah, that's a pretty good acronym or visualization. And then somebody said, yeah, but a tsunami kills people, and like, why are older people a tsunami killing people? And so, anyways, the tsunami concept became sort of passé, or wasn't politically correct. But the idea is that there are differences. Older adults in the hospital tend to get fewer invasive procedures, sometimes for good reason, but in other cases that they just are thought to be too old. They also get less intensive resources, such as they may not go to the intensive care. And again, sometimes it's a call that we'll discuss, because an older adult is closer to their end of life than a younger adult in the hospital. And so we have to do some predictions as to how many years of extra life expectancy might be gained by a more acute or intensive approach. And the other point that I was going to make is that the acuity of care, or the acuity of the illness, is no different between a young and an old person. So that's want to dispel that thought. So it turns out there's a lot of variation about older adult preferences in care. Some really want everything done, all cost, all, whatever it takes. And then others not so much. And so and it's important for them to identify what their preferences are. But generally, well, both patients as well as their families, and there's just an overestimation of lifespan, life expectancy. Older adults typically think they're going to live 5 to 10 years longer than they actually will live, based upon actuarials. And that a lot of times people make assumptions about older adults as to what they want. And so that's why we always encourage and ask what matters most to the older adult, trying to establish documentation of what they would wish for in terms of circumstances where they couldn't speak for themselves. So we'd like to talk a little bit about hospital-associated disability. The big problem with hospitalization is that there's an awfully high risk of older adults losing their independence and also becoming institutionalized, the dreaded nursing home. Although, having worked in nursing homes most of my career, I don't find them so dreadful, but the perception is there. It's an important point that when people go into the hospital, and if they're over the age of 65, a third of them are going to leave the hospital with a new disability. And so these are called HADS, or I don't know if that's the right term, but hospital-associated disability. And what are those, and what do those look like? So HADS are basically the reason that half of the adult population goes onto a trajectory or a pathway for frailty. My comment is that taking to bed can be a death sentence. We often convey that message to our trainees, that a lot of times older adults come in and they are sick, and they say, well, Mom, you need rest. And so the family reinforces this concept of taking to bed. But for each day in bed, it's 3 to 5 days of recovery. And so with the average length of hospitalization being 5 days, you're already talking about a 30-day recovery period. And if they don't recover within 60 days, they're not going to recover ever again. And so there's a very tight window by which we can get people to get their legs back and get back to their functionality as they were before they got into the hospital. So the risk factors for HADS, these age-acquired disabilities, or hospital-acquired rather, are age itself. If you have several activities of daily living or instrumental activities of daily living issues, that's going to further accelerate the functional decline. Lack of mobility, again, that bedbound status, tethers, tying the patient down, good gravy. That's back medieval days. All these contributed to mobility limitations and further disability. Cognitive impairment can be a factor in the disability acceleration. So if somebody comes in with delirium, they have a lesser chance of recovery or a longer hospitalization. And so delirium avoidance through programs called HELP, H-E-L-P, are really very good things for healthcare systems to adopt. And then I always comment to people that a low normal or a frankly low serum albumin is a really bad prognostic sign. So if you find somebody with low protein levels or low albumin levels, Well, 50% of them with low albumin will be deceased after 1 year of hospitalization. So it's a very strong indicator. We know that delirium is probably most expressed in the hospital setting, maybe a little bit less so in long-term care, and maybe only 1% incidence in the ambulatory care setting. But there's two types of delirium, and there's the epidemiology is such that some people will come in with delirium. You can see up to a third, and then up to 10 to 15% will acquire delirium somewhere later in their hospitalization. So they come in just perfectly fine, walking, talking, or whatever, and then all of a sudden they get goofy. And we're going to talk about what that goofy means. The delirium itself increases risk of death, falls, institutionalization, and worsening cognitive function. So to recognize it, we have separate presentations on delirium assessment and treatment, but basically you have to consider delirium when somebody's not paying attention. Okay, and that doesn't mean with this lecture, so no worries there, quite honestly. But when somebody starts not following your conversation, or they have disorganized thinking, going from one thing to another thing, like, the sun's so bright today, and boy, did you see where my socks went? They just can't keep the conversation flow going. And then also altered consciousness. Are they hyperactive, like, on the edge of their seats, or are they pretty much sleepy, somnolent? Okay, so that would be associated with hypoactive delirium if they were not very active. So you want to reduce delirium by a couple of things. One, you have to recognize whether they are cognitively impaired. You have to recognize sleep hygiene, mobilization, address visual impairment, hearing impairment, and also hydration status. And so these are the fundamentals of the HELP program. So it's a checklist. How do we reorient and just non-pharmacologic interventions. There's been a lot of studies that have looked at medications that might prevent delirium, and they haven't worked out so well. So stay tuned for that. But we do know that if we avoid certain medicines, particularly the anticholinergics, and I have this discussion with our hospitalists all the time who just habitually prescribe Benadryl or diphenhydramine for sleep. They said, "Oh, it works, it's harmless." And I go, no, it's very anticholinergic. It causes delirium down the road, and then you end up giving people Haldol, and you made them sleep with the with the anticholinergic Benadryl, but then you made them delirious, and then big problems from there. So anyways, getting our hospitalists or getting all of our providers to understand the connection between unsafe that's why we call them PIMS, potentially inappropriate medications, that will set the older adult up for adverse events. We certainly want to make sure that the confusional state is not associated with an underlying infection, metabolic abnormalities such as calcium problems or low sodium. Unresolved pain can often, particularly in the older adult, can be a problem and cause delirium. So I made the point that we want to avoid anticholinergics as a means for preventing hospital-acquired delirium, preventing infections, so not using catheters whenever possible, getting rid of tubes and catheters for bloodborne infections or urinary tract as quickly as possible. Frequent orientation is always important. So when you go into the room, you say, "Hi, Mrs. Jones. Today is Tuesday. How are you doing? It's Tuesday morning and it's 9 a.m. Can I take your blood pressure?" So you do those orientations. The last 2 points there is really what I call tough love. Try to get people up out of bed, even if they gripe about it. Of course, let the family know what you're doing so they don't think you're being abusive. But sometimes you have to be a little assertive, to get people up out of bed, but also making sure that they're not in pain by the change in movement or transfer. And then promoting nighttime sleep through non-pharmacologic means, certainly adding melatonin to the regimen, letting people know that's not going to put them to sleep, but it's going to help with their sleep hygiene doing deep breathing exercises, not disturbing people in the middle of the night. If you can possibly avoid taking vital signs and let them sleep, that would be good. So the big problems with medications are, of course, polypharmacy. And so once you have 5 or more medications, you've got at least a 60 to 100% chance of a drug-drug interaction and or a side effect. So a lot of times it may be diarrhea, and then all of a sudden you think, oh, they got diarrhea and they've got hospital-acquired C. difficile colitis. Then you add an antibiotic until you're waiting for the test to come back, and the cascade starts. Part of the reason that there's adverse events with medications is that there may be provider gaps in knowledge or even attitudes. And I shared with you the story about the Benadryl story. I think it's probably a combination of lack of knowledge and probably a little bit of attitude, because doctors don't want to be bothered in the middle of the night. Mrs. Jones can't sleep. Can you give her a sleeper? No, we're not going to give her a sleeper, and that should be a standing order. No sleepers on the geriatric unit. The adverse drug events are driven by, again, the number of drugs. If there was a history of adverse events, and just look at the allergies, right? If people have a lot of allergies, they're going to have a lot of adverse drug events in their history. Any chronic conditions with end-stage organ failure, whether it be heart, liver, or renal, are setups for adverse drug events. So some of the interventions that we can do for adverse drug events are to do both daily and discharge medication review, which is critical, and making sure the patient knows what those new medicines are supposed to do, how long they're supposed to be used for, and what to report if they have any potential side effects. You want to discontinue medicines that have low therapeutic value, so the sleepers only garner 30 minutes of any kind of sleep extra relative to placebo. And you'll always get the person that endorses, like, oh, I can't get to sleep without it. So there's a psychological dependency, quite honestly. There's no physiologic evidence that these sedatives really induce much of any kind of sleep, and the quality of sleep is awful. So if somebody wants good REM sleep, don't take a sleeping pill. And then just looking at drug-drug interactions, usually we call the interprofessional team, to include the pharmacist for that. I think most hospital systems do have the pharmacist on board for that. In terms of sleep disturbances, a large group have sleep difficulties. Part of it may be because their medications are being changed around, certainly the medical illness, shortness of breath. Other extrinsic issues such as noise. I mentioned measuring the vital signs in the middle of the night, phlebotomy. All these things can interfere with somebody's sleep hygiene. Another issue to address is nutrition. So somebody did a study. I can't quote you the article, but I read it. And so it basically indicated that hospital diets are starvation diets. I mean, you do not get enough calories to sustain yourself, with the 1,500 calories a day. And so as a consequence, you've got all of these different intersecting issues, particularly with older adults, 10 to 15% who come in protein, calorie malnourished to begin with. And then another quarter of them have some form of borderline malnutrition and might even include vitamin deficiency, malabsorption syndromes. And then as a consequence, they may have either electrolyte, either sodium or calcium problems, or like we see a lot of vitamin deficiencies. I'm absolutely shocked. And even because somebody's taken a multiple vitamin doesn't mean they're absorbing the vitamin properly. And that's because older adults tend to get atrophic gastritis, or they're not taking, vitamins that have anything in it that's, of any value. A lot of these plant medicinals, just as a reminder, people who take plant medicinals, the vast majority of them, 80% of these medicines don't have what they say they have in them, and they don't have the amounts of the plant medicinal that they are advertising to have. And at least 60%, is my understanding, will have contaminants in there that are not even reported. So we want to look at reasons for poor nutrition, and part of it is, do they have ill-fitting dentures, or do they need dentures? Do they have problems swallowing? And just doing a bedside swallow test, asking them to drink some water, and if they start, coughing about a minute afterwards, then you might want to get a swallowing evaluation. Sometimes patients are shuttled from one place to another for tests, and they don't have enough time to eat, or the food comes up cold and it's not too appealing. Some medications will dry the mouth out and make food unappealing. COVID may cause loss of olfactory senses, so they just may not have a sense of smell that is required for a good appetite. So just a key point here is always consider supplements and maintain fluid and electrolyte balance. One of our partners in our GWEP grant is Edgewood Group. They circulate fluids in their assisted living facilities to make sure people are hydrated. And I've seen that done in long-term care facilities where there's just a cart that goes around. Actually, we implemented a soup cart where we went around the nursing home and offered 2 kinds of soup for everybody to help them with their hydration. So that was pretty good. Or they would have a fruit juice cart, or liquid cart. So just to touch base about the never events, these are Medicare mandated, and hospitals don't get paid if they goof up. I say goof up. It's sometimes unavoidable, but a lot of these are avoidable instances, and they've been identified because they're high costs. They tend to occur a lot of times, and they're potentially there are potential interventions for them. So I do legal medical advice. I'm a consultant, and so one of the never events is pressure sores. And so a lot of lawyers say, "Oh, so and so got a pressure ulcer in the hospital. That's a never event. That should never have happened." And they're shocked when a geriatric expert like myself comes by and said, about 15 to maybe 20% of pressure ulcers are unavoidable. I mean, they're destined to have a pressure ulcer no matter what you do. And so they're shocked with that information. But that is true, that there are people who, because of what we call skin failure, are 100% certain to get a pressure ulcer. But anyways, the never events are over a couple dozen issues that occur in hospitals that have been identified. And the main ones we want to talk about with the older adults are the pressure ulcers, bladder infections, and falls with injury. So the hospital fall rate varies from unit to unit, and from hospital to hospital. And nobody's got a good handle on why that variation occurs, but it would be a true statement that they cost a lot more money when somebody falls in the hospital, particularly if they have an injury or a fracture or traumatic brain injury. So it's important to assess gait and balance. My favorite story was one of my former geriatric fellows who was on our hospital unit as a medical resident. And he was all excited. He says, "Oh, I got Mrs. Jones ready to go. We're going to discharge her today." And Mrs. Jones wasn't going anywhere because Mrs. Jones couldn't get out of bed. But I asked him, I said, "So have you tried to walk her and see if she can get to the taxi cab that she needed to go back home?" And so he offered to, hold her hand and get her out of bed. And she couldn't stand up. And so it was a revelation, which actually led to his becoming a geriatric fellow, how important is something, just, ability to transfer from bed, to stand, how important that is in terms of medical care. So you want to prevent falls by basically promoting safe mobility. Now, what does that mean? So part of it is, don't tie people down. Sometimes people show poor judgment, particularly if they're cognitively impaired, and the first reaction is posy, and that's not a good way to go. The better way to go is with a sitter or a family member to be next to the bedside. And likewise, if you have a low bed, so that if they do get up, that they don't have far to go when they do fall. Decluttering the environment. So I have pictures of, particularly in, it occurs in hospitals. People hoard things, and then all of a sudden they have stacks and stacks of stuff, including water bottles and so forth that cause wetness on the floor. But the important thing is that you always want to be available and help assist. And part of the problem is that a lot of hospitals, as they reduce their staff load, the relationship of the nursing staff and rehab staff to patients has been increased. That ratio. There's more patients per healthcare worker, and that's not a good thing in the hospital setting. In fact, Kaiser Permanente, the doctors and nurses went on strike, not so much for pay, but it was because they were putting patients at risk by understaffing and trying to have cost savings that way. In terms of pressure ulcers or pressure injuries of the skin, there's a steady rate that has occurred. And the problem with them is that, particularly on the sacrum, these can be painful. They prolong hospitalization, and they're costly, both from the hospitalization's point of view, but also from the legal point of view. So I think the standard is that patients really should have their skins inspected daily. And this I would say also should hold in long-term care. I mean, it may be aspirational, to do so, just again, because of the nursing staff is always short. There's a 10% overall shortage across the country. But again, as best possible to get staff. And I always included family members, particularly in long-term care and in the hospital. So, if you're helping mom or dad with bathing or getting up around, here's the spots I want you to check for either redness or skin discoloration if they happen to be a person of color. So we know that older age, frailty and low body weight, urinary incontinence or stool incontinence, these are all factors that play a role in acquiring skin ulcers. Excuse me. In terms of urinary tract infections, they're almost exclusively related to urinary catheters. We used to put urinary catheters in everybody to monitor their fluids, and you really don't need that. The I's and O's, they would always see that order. My favorite was, before we had typewritten or click physician orders, we'd have to write down strict I and O's. I don't know what the strict meant. Right? You come with a ruler like a grade school teacher and spank somebody for not being strict. I don't know what that means, but because there's always other fluid loss from just the simple act of breathing, and how do you measure that? But anyway, so much for the strictness. Sorry. So we want to make sure we use the catheter when it's actually needed. So if there's an outlet, bladder outlet obstruction, then it makes sense. In some cases, if there's perineal surgery or something that requires a very close monitoring of urinary function, then that would make sense. In some instances, open sacral or perineal wounds with patients who are not continent, so then a Foley catheter may make sense. And then finally, just an issue perhaps as end of life comfort measure would be a way to consider it. So in terms of geriatric assessment of the hospitalized patient, I think it's really important right at the get-go to think about life expectancy. If you have a 92-year-old with acute pneumonia, I've who's been hospitalized, I've had a conversation with the family that there's this old adage that pneumonia can be an old man's friend, and so we have a discussion about whether we would even treat the older adult for pneumonia. Everybody assumes that once they're in the hospital, they got to be treated, and that's not always the case. So taking into account life expectancy, what about their functional status, and again, what is their cognitive or brain status, their the body, such as the comment I made about the lady that couldn't get out of bed, their psychosocial support. Even if they get better in their hospitalization, is there anybody back at the house who can help them transition back into independent living? And then also looking at things like multi-organ failure. So is there skin breakdown? Do they have bad lungs? Do they have COPD? Chronic kidney disease? Are they on the verge of having dialysis? All of these things play a role, and they're additive. So just because somebody has, let's say, advanced coronary artery disease If they also happen to have diabetes with peripheral vascular problems, those are complicated cases and may not recover. And so, again, the discussion is always going to go between trying to decide to do curative care or comfort care, so that we're always at that juncture with the older adult. We also want to apply the geriatric 4Ms, which we've talked about pretty consistently here in these presentations. Parts of the assessment, I'm not going to do such a deep dive here, but just in these slides will be available for you. But certainly, again, looking at the medications, you want to know a little bit about the social history, what their social support is. I always ask if people have family members in the area, or if not, do they have somebody that can help them? In terms of the review of systems, it's important to identify any weight changes, any changes in diet. They may not be eating as well because of a sore dentition, or there might be medications that are making them feel nauseous and they don't feel like eating. Issues about continence. How many times do they go to the bathroom at night? Have they had any history of falls? And then also visual and hearing problems. In terms of the physical exam, I think it's really mandatory that people do supine and upright blood pressure checks, so checking orthostasis, checking obviously pulse oximetry and oxygen, cardiac rhythm, so you can get a EKG for sure, but also just a simple hand on the pulse can let you know whether they're in skipped heartbeats or not, or have an irregular rhythm. It's also important to assess vision and hearing. So at an arm's length away, you will be behind the patient and whisper to them. You can say 99 and ask them to repeat what they've heard. You also, as best possible, want to assess their ability to transfer, or do they need transfer with assistance? A lot of times that's a nursing assessment, but I think it behooves the providers to also get a reading of the tea leaves as to whether they're the patient is bed-bound status or not. So it's important to understand what the activities of daily living were, not only on admission, but also prior to admission. So if they were completely independent and now they can't groom themselves or bathe themselves, that's a significant change in status. In terms of sensory impairment, one of my favorite activities was to look for the eyeglasses on the table side. I'd pick them up, hold them toward the light, and see how much fingerprints and smears were on the glasses. And I always carried alcohol wipes to clean the glassware, and then put them on the older adult. Certainly checking for cognitive impairment. We want to also look for people that are bedbound to use low heparin, low molecular weight heparin therapy if they're not anticoagulated already. We already talked a little bit about nutrition, and the axiom of turning everybody every 2 hours is standard of care, but it's no evidence for that. People can develop pressure ulcers within 20 minutes, let alone 2 hours, but that seems to be the steady state for keeping people moving around to prevent ulcers. Talked a little bit about sleep disturbances and some of the interventions, and then also the hospitalization may be an opportunity to get people up to date on their vaccines, particularly with tetanus or pneumococcal. It's important to do a daily evaluation, addressing their mobility. Are they recovering in their activities of daily living if they have a gap? Again, we want to up and chair as much as tolerated, get them mobilized. And we want to discontinue catheters and all the tethers that we have as soon as possible. I want to turn now just to talk a little bit about these different units. So there's GEMS, there's ACE units. I already mentioned the health program for delirium prevention. One of the new things is there at the bottom is the embedded geriatrician. I tried to set that up when I first came to Sanford Health, and it just didn't work out. There was not enough geriatricians to create an embedded geriatrician in the hospital. So we've been trying through our geriatric fellowship to create more geriatric expertise so that they can join the teams in an interprofessional manner. But that works pretty good, and you get good outcomes as a result of the embedded geriatrician. All right, so as part of our process, for ECHO, we like to have a case report. So here is our case report for discussion. We have an 84 male hospitalized with pneumonia. He has minimum cognitive impairment, diabetes type 2, hypertension. The medications, when he came into the hospital, he's on antibiotics, ceftriaxone and doxycycline. He's on enoxaparin for blood thinning, and he gets long-acting insulin. Early on in the hospital, on day 2, he's found to have normal vitals, good oxygen saturation. He's oriented. Blood tests are all within normal limits. However, later on the same day, he was unable to recognize his daughter. So what's everybody's thought? You can put in the chat box as to what's just happened. Any brave souls out there that want to make a quick diagnosis? This guy suddenly stopped recognizing his daughter. Okay, so we've got one thought. It could be a UTI, low oxygen. Okay, yeah, you're really jumping the gun on what it is on the differential. So we're thinking delirium, and yeah. So thank you guys for jumping right to the diagnosis. So the first, and this is actually an important point, because when I have in the past done surveys as to how people document acute confusional state or delirium, it doesn't get documented. It gets documented just like what you guys are doing, which is perfect, in terms of identifying a underlying problem. But we have to connect the word delirium or acute confusional state with rule out UTI, rule out hypoxia. So thank you for bringing those up. This is just a wonderful opportunity to illustrate an ongoing point that occurs in all hospitals. I mean, it's just a culture that we have of not documenting delirium. All right, so on the exam, normal temperature, stable vital signs, appears tired, somnolent, but responds. He's only oriented to self and has a low attention span, and the neurologic findings are non-focal. So I think we know where we're going. So the question is here, which of the following tests is most appropriate? Do you want to do the delirium-based confusion assessment method? Do you want to send them for a CAT scan of the head? Do you want to measure blood gases and potentially look for CO2 retention? Or do you want to do finger glucose stick? So just think about your answer currently. Let's see if I can drop the answer here. So the correct answer would be initially to do the confusion assessment method. And probably at the same time, you're going to want to measure his oxygen, and you're going to want to measure his glucose to make sure he's not hypoglycemic. But again, all these get done pretty much simultaneously. All right, so what I'd like to do is just summarize what we talked about here, is that we know that hospitalizations can lead to adverse events. They can, most importantly, lead to worsening function, whether that function be cognitive, physical, or psychosocial functioning. And certainly death is an ever-present concern. We have to be mindful of the never events, trying to prevent falls and pressure ulcers in particular, try to avoid the use of urinary catheters that lead to urinary tract infections. And getting back to this word of my famous mentor and predecessor, Dr. Swanborg, to really remember to have early reactivation as best possible. Get the person mobilized, get physical therapy. Don't wait for physical therapy to come at the end of the hospitalization when you want to put them, place the person in a nursing home. Get them on day one. And so as a plan, do, study, act cycle for anybody that's involved in hospital care, Having a standing order that physical therapy will evaluate the patient on the day of admission would be a good thing to do. And then, of course, monitor whether, they improve in their outcome metrics in terms of shorter length of stay. I guess I really didn't say that for those that are interested in health outcome metrics, that when you apply geriatric principles of care, no matter who you are, whether you're a geriatrician or not, you will find that the metric of hospital length of stay will decrease considerably. And so these are all, by a half a day, sometimes a full day. And hospital administrators just love that kind of data. And it's remarkable that the data is out there, that more hospital administrators don't really understand the value of geriatrics as a consequence of that. So we keep, harping on this issue, that if you apply the geriatric 4Ms, and at some point I can share with you some of the data that came out of Chicago that showed that it has a very, very strong impact on reducing hospital length of stay. The other points that I wanted to make, there's that last one, is that geriatric units or embedded geriatric consultants and certainly interprofessional teams all improve health outcomes for the older adult. And that's what we're all striving to do. Is somebody asked me, why do you want to apply the geriatric 4Ms? And I said, well, because we want to have better or improve or strengthen the care of older adults. And we can always talk about where those gaps are, in terms of under-recognizing delirium or under-recognizing malnutrition. But again, if we apply these geriatric principles, we're going to get good results.